And I am honored to be here this afternoon. While I would love to have interaction and discussion, I think we all see challenging things, but I am sharing real clinical data, so please no pictures of the patient information. We see, as I said, patients from 31 to 87 with a variety of questions and backgrounds. And so this was a patient, I'll go through kind of introduction, case, background, findings, what we talked about, and then some questions that I have struggled with as I have seen some of these patients. So again, format for HLMS case presentations. So our case background, this patient was an executive in his early 50s, follows a whole food, plant-based diet, no animal products at all, and has taken his diet to the point where he has no added fat. So sauteing foods is not done in oil, it's done in broth or water, and is quite strict about diet. No medications, no supplements. He does exercise regularly, but he has dystonia, and this impacts ability to complete duration activity with the lower extremities. Family history, both parents are alive and healthy. One grandparent lived to 100. When I asked, how old do you feel? Probably in my 40s, a decade or so younger than his physical age. So, from the U.S., the East Coast, 50, male, no allergies. And as we dig a little deeper, not only has he struggled with his dystonia, but he shares a history of disordered eating. As an adult, evaluations have revealed a mildly elevated lipoprotein a, I think about 78. Our reference range goes to 75, so when I say mildly elevated, and has had some surgical joint repair. So as he comes into clinic, really a very normal exam. He does have some evidence of dystonia as you have him walk across the room. Heart rate is excellent at 51, blood pressure well-controlled 120/76, and weight is 52 kilograms, not a particularly tall patient, but BMI overall is 20. So as we review his laboratory studies, CBC is normal, comprehensive metabolic profile including liver enzymes is normal, HDL is nice at 49, LDL 79, lipoprotein a was 90, not 78, but again, mildly elevated. Vitamin D is rather reduced at 14, and if you note his vitamin B12 was significantly low at 120. His TSH was slightly elevated, T4 was normal. He did have the blood multi-cancer detection test and no evidence of malignancy. He did meet with genetics and they offered further genetic testing, whole exome sequencing, etc. The patient denied after reviewing pedigree and felt that he did not have any elevated risk and did not want any further genetic testing. In our clinic, we do body composition testing with bioelectrical impedance on all of our patients. The things that I tend to pay attention to, so weight was 113 pounds. Again, I said not a particularly tall patient, but you can see weight, skeletal muscle mass, and body fat are all at this kind of lower end of normal, with the skeletal muscle mass actually falling a little bit below what they would consider reference range in this population. BMI 20%, body fat is 14%. And then if we look at distribution of this lean mass, you can see upper body and trunk are normal, but we see evidence of that dystonia and impairment in the lower extremities with the lower muscle mass in the legs there. He did have a stress EKG test, negative for ischemia. Exercise capacity was reported to be normal. He did not have VO2 max added on. But our cardiologists have been doing a lot with EKG AI, and so with a 12-lead EKG, they predict valvular disease, history of cirrhosis. They actually predict gender, which is quite challenging if you have a female patient with a male-predominant gender, as it sometimes changes around menopause. And then as hormones normalize again, we may see concordance again. But one of the things that they do report is this EKG age. And you can hover, this was his first time to the clinic, and so his chronological age was very closely correlated with his EKG age. And they do say that it's within about a 6 to 7 year range for the two correlations there. I do have patients as they come over time, they do plot this nicely along the line, and this is anecdote, but some track nicely linearly, and then they jump up for a year, and I say, what happened? Well, that was the year I got a divorce. That was the year my child died. And it is interesting to see that acute stress on the cardiovascular system. And so as I talked with this gentleman, certainly he had a very strict diet. He was not apparently talking to his healthcare professionals about being solely plant-based with no supplements, and subsequently had this B12 deficiency. Certainly, I think his very restrictive diet had led to his low vitamin D there. The mildly elevated lipoprotein A, we can argue about. His LDL was 79. I felt no significantly increased risk there. And then we did spend quite a bit of time talking about this lower extremity muscle mass and the dystonia, particularly as we get older, and the impact of physical function impairment potentially, and how can we help maintain and build that muscle mass in the legs with the challenges that he had with certain types of exercise. What I struggled with in part with this patient is, as we really talked about his diet, he asked me, are there evidence on my blood tests that I have hurt my body with my restrictive eating? That was an unusual question for me. And certainly I am aware of the discussion about calorie restriction and enhanced lifespan, but when do we get into an eating disorder? And this gentleman did share past history of disordered eating, concerns from family about disordered eating, and the social impacts and connections with others of his behaviors there. And so I struggle a little bit. I know there is evidence base for this, but also realize that there is significant psychological impact and social connection impact of eating and the social nature that we have. And if it's causing significant strife and interactions with others, when do we say too much? And when do we say we need to liberalize that and really think about, from your perspective, it's not just what you eat, but how and the relationships that you have there. This is not the only patient I've seen that has a history of eating disorder that has really been interested in calorie restriction or fasting or other patterns that are quite similar to their disordered eating in the past. So for this patient, I did tell him he had to start a B12 supplement with no animal proteins at all. He needed to do that. They did ask about, can I use nutritional yeast? Isn't that fortified? And I said, yes, but with a B12 of less than 200, you have to take a supplement. Certainly getting started on vitamin D supplement. He was supposed to meet with a dietitian for diet counseling. Several of these patients I tell need to meet with a dietitian and then they cancel because they don't want further information about how to truly address some of the underlying challenges that they have. I did refer for a physical therapist or exercise specialist to try to help figure out how we can, what exercises are we able to do with those lower extremities that don't exacerbate the dystonia. He's also meeting with neurology to discuss further options there. With that mildly elevated lipoprotein A, he did have a pending consultation with cardiology as well to discuss future risks and predictions there. So I think that my challenge with this case, and I'm curious how others address this, but as we approach longevity, can you go too far? with some of the restrictive patterns and some of these lifestyle interventions that we know are important. And many people, as Nicole indicated earlier, don't do these basic lifestyle things. But what happens when we get to that opposite extreme? And people may be carrying some of these interventions. Or is it still appropriate where he's not actively losing weight, and so he's maintaining where he's at this point in time? And so how do we find that right balance there? And how do we use that data? I am still concerned that he wanted to know about potential end organ damage due to his eating on his laboratory tests, because normal data isn't necessarily the best if people may be participating in patterns that may eventually cause harm, and we're trying to promote that optimal health. So I did some reading on orthorexia and orthorexia nervosa. Are you guys familiar with those terms? Who's heard of orthorexia? Yeah, a few. So this is obsession with eating healthy and not eating anything that may be considered unhealthy. And so that's been a newer term, and then the references for the EKG, AI, and just calorie restriction. So I'm curious, other thoughts, other experiences with what is that balance? How do you draw the line? Yes?
So I have a question. What are the inflammation biomarkers?
They were all normal. His inflammation biomarkers, CRP, ESR, all normal.
You need a calcium score?
I don't believe he had a CT coronary calcium score. He just had the stress EKG.
So I think, like, looking at his BMI was a blessing for him, because the elevated lipoproteinyl A can create, maybe soft plaque or already, calcified plaque. And so I think if he doesn't have, he has a proper BMI, visceral fat is really low, even though, he has, lean muscle mass can be improved on the lower extremity. But I think he has normal inflammation, like no inflammation at all. Lipoprotein A should be addressed, right? I have lipoprotein A elevated. So everything should be optimized. So I think his main problem is the cardiovascular disease right now, not the diet or maybe the dystonia. So I think if his soft plaque or hard plaque are inexistent, that's a blessing for him to have this type of diet. So this is my my observation. That's probably not an answer you were looking for, but.
Others, yeah.
Thank you. Interesting guy. My main concern with him would be frailty, and I took a quick look at your DEXA data, but did you have the bone density up there?
So it was bioelectrical impedance, so I don't have bone density data on him.
So you need a DEXA on him, for sure. And also, I'd want to know what his appendicular lean mass index is, and on his nutritional history, really get an idea what his protein intake is like, so we can at least look at muscle protein synthesis drivers for him.
Yeah, and so, I did review what do you eat for breakfast, what do you do for lunch, what do you do for dinner, and it does sound like he's getting a good source of legumes, protein, a protein supplement multiple times throughout the day and splitting those up. But then he did share that he does periods of prolonged fasting. And what is prolonged fasting to you? It sounds like it was about 24 hours, which is, in my mind, not particularly prolonged, but still a lot for a patient with
a bit of a recipe
very
for
low
disaster
lean muscle mass.
With the dystonia, right?
Yeah.
So risk for falls and frailty-related disease and morbidity and mortality. So
Yeah, agree.
There's another question or comment there. No, next to your. I'm small. Don't know if I'm supposed to stand up. Can I ask a simpler question? And apologies if I missed it. What was his motivation for coming to see you in the first place?
Yeah, and I think grandparents had lived to 100. He expects to have a long life. How can he try to optimize that as much as he can?
Because I wondered, given he asked such quite a poignant question to you, saying, have I harmed myself? We can go through, it's a valid point about frailty, it's a valid point about his heart, but these are all our concerns as doctors. And I guess I'd be more concerned to hear from him, if that is one of his fears, if we're going to have to unpick disordered eating, if he is scared he's harmed himself, using that can then be quite powerful. You can say, well, look, actually, you do have, maybe you have some soft plaque or whatever, so can we be less restrictive around your eating, because actually we need to include this to make you healthy so you're like your grandma. But I think sometimes we lose track of what's actually we see plenty of patients who don't make lifestyle changes, and in order to backtrack to make them do that, we need to understand why they came to see us in the first place.
Mm-hmm. Excellent, and yes, trying to unpack all of that and what they
Is
say
part of
in a
consult.
visit and what they don't say, and reading between the lines, and yes, I think part of that is going to be that longitudinal relationship as well. What is shared in the first visit may not be what's shared in the second visit or subsequent visits.
Are there other comments?
So I like to just provide a positive note. Working in neurology, I see patients like that on a weekly basis. So, and having followed their, the history of their clinical case, they end up, after a B12 supplementation and replenishment, they end up improving those symptoms, and there are little and to no complications to that. They end up healthy and well, and we release them from the hospital. So, but I think for our HLMS program, it is very important to educate vegetarians to take supplements and to implement them to their diet. Yeah.
And I saw a hand back there. I think to that point, thank you for that. Making sure that GPs talk to their patients about what are you eating or not eating. Because to get to a B12 level of that, he'd been doing this for a while, and no one seemingly, or at least he didn't acknowledge that anyone had ever told him to supplement. There was a hand,
Yeah.
yes.
Maybe one more thing to add to that, supplementation in vegetarians and vegans. There's a case to be made for creatine supplementation, particularly in this individual with the low muscle mass. There's some evidence showing that creatine stores are lower in vegans, and even cognitive function can be improved even in younger individuals. So that might play a role in healthy aging going forward.
You. Right here.
There was
One more.
other one. In the meanwhile, did you consult a psychologist, and did you do a psychological testing? Because I...
Thank you for stealing my next question.
Okay.
Yeah.
Okay, ask it again.
Yeah, I was just about to ask that. So was this gentleman tested on at least PHQ-9 and anxiety scoring? Because obviously his orthorexia would be linked with some sort of anxiety, health anxiety, at least, to say the least. And the second part is, given his B12 deficiency was probably long-standing due to his habits, was there any anemia? And how surprising that he didn't have that anemia. So what was he doing to avoid that?
Yeah, no anemia. And I don't know what he was doing to balance that. It was interesting because to the dystonia and those points, he told me he'd been worked up by neurologists multiple places, multiple times. Every test has been done. And so I don't know if the B12 is the outlier or if the B12 hadn't been checked, right? I didn't have access to those records. The anxiety score, those things had returned as normal. There was discussion about working with a therapist or psychotherapist, and so encouraged that relationship continue.
Thank you.
Yeah. All right.
Do you want to continue?
No, I think I'm...
Sorry. Then one more question. How did you measure muscle strength? Or did you
Yes.
measure maybe not hand grip strength?
So yes, he did do hand grip strength. We did do a 6-meter walk. He was below average for both of those, actually, for age-referenced norms, which I think would be consistent with some of the other test results that we had for him.
Are there any other comments or suggestions for this case? I would love to know what the outcome is, Sarah.
Well, I just saw him, so I don't have an answer for you, but hopefully next year,
Yes.
right? Okay.
Good.
Thank you.
If there are no more questions or comments, give a big round of applause for Sara. Honest.